Good evening and welcome to the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Health Care in Your Practice. My name is Cynthia Pankella and I am the Senior Director of Physician Services at the American Osteopathic Association. And as a member organization representative of the BHI Collaborative, I am very pleased to welcome you to our third webinar in this series. Before we begin, I have a few housekeeping items to go over. So first I want to tell you to please utilize the chat box for any questions you may have. We encourage attendees to interact and share comments or questions in the chat box while our panelists are presenting. Please note that this webinar is being recorded and that both the recording and the slides will be shared in an email following the event. A survey will also be included. And then the staff of the collaborative encourages you to share your feedback as we plan future events. Following the presentation, we will take the question and answers that you are typing in. So, next slide, please. This educational series is a part of a suite of ongoing activities by the BHI Collaborative dedicated to equipping physicians with necessary knowledge to sustain a whole person, integrated and equitable approach to physical, mental, and behavioral health care in their practices during the COVID-19 pandemic and beyond. Next slide. As I mentioned, these webinars are a collaborative product of 8 of the nation's leading physician organizations established to catalyze effective and sustainable integration of behavioral and mental health care into physician practices. With an initial focus on primary care, the collaboration is committed to ensuring a professionally satisfying, sustainable physician practice experience and will act as a trusted partner to help them overcome the obstacles that stand in the way of meeting their patients' mental and behavioral health needs. Today's webinar, titled Keys to Success, Implementation Strategies for Virtual Behavioral Health Integration, will examine how practices can virtually support the behavioral health of their patients. At the end of tonight's discussion, as I said, we will have a Q&A with our experts to explore common issues and/or concerns that you may be experiencing in your own practice. Before I introduce our speakers, I would like you to just take a few moments to look through this disclaimer. Just again, noting that today's webinar is being made available to the public and is being recorded. The purpose of this webinar is informational only. And of course, you should consult a professional advisor for specific medical, legal, financial, and/or other advice. And then without further ado, I am pleased to introduce our speakers. Our moderator for this evening is David Leskowitz, DO. Dr. Leskowitz is the Medical Director of Outpatient Addiction Services, Department Chair of Family Medicine at Pontiac General Hospital in Pontiac, Michigan. He is also the Medical Director of Inpatient Addiction Services, Adult Substance and Detox Facility at Connor Creek Life Solutions in Detroit, Michigan, and an addictionologist at Western Wayne Family Health Center, an FQHCC. Dr. Jay Shore is the Director of Telemedicine and a Medical Director at the Stephen A. Cohen Military Family Clinic at University of Colorado Anschutz Medical Campus. And then his colleague, Dr. Frank Degruy, is the Director of Primary Care Outreach and Research at the Stephen A. Cohen Military Family Clinic at University of Colorado Anschutz Medical Campus. Dr. Barry Sarvet is the chair of the Department of Psychiatry at Baystate Health and professor and chair of Department of Psychiatry at University of Massachusetts Medical School in Baystate. And Dr. Brenda Anders Pring, who is the chief of pediatric urgent care at Atrius Health, Kenmore, and pediatrician at Atrius Health, Copley. And we're very pleased to have them all with us this evening. And with that, I will turn it over to Dr. Leskowitz.
Well, thank you. Thank you all for attending. Thank you for the moderators, and thank you all for coming in today. I'm really excited to introduce this webinar by the BHI Collaborative on the keys to success in implementation strategy in what is so important and available to all of us today, virtual behavioral health integration. As you were already heard, my name is Dr. Leskowitz. I am the founder of a primary care practice in Michigan that offers integrated primary care, behavioral health, and addiction treatment. Most of my life, I was a traditional osteopathic family physician. Back in over 10 years ago, I became board certified in addiction medicine, and at which point I had started serving as addiction services director in 2 federally qualified healthcare centers, also known as community healthcare centers or government clinics. Most recently, we faced challenges in opening up more government sites during this COVID period. And we can get into that a little bit later. But behavioral health integration is so key in my field in addiction services, to have all of us to be able to have family medicine, psychiatric services, talk therapy integrated, and to leverage this into virtual care is a critical issue during this period. And I'm grateful to have this opportunity to be on the webinar to encourage all of us to participate in telemedicine to provide these services. As a starting point, let me just share a few statistics, and thank you for sharing these with me. According to SAMHSA, close to 19% or 1 in 5 US adults suffer from mental illness. And I feel this has just gotten more lately, and sicker patients. Nearly 19 million or 1 in 12 American adults suffer from substance use disorder. Again, I feel that we're getting sicker patients, some of those not being able to have care, but with virtual medicine and integration, we are all fortunate. The good news is the proportion of substance use disorders patients that are now being able to receive MAT or medication-assisted treatment is finally increasing. And looking at the pediatric population, as our pediatric specialists will tell us, 3.2% of children aged 3 to 17 are diagnosed with depression, 7% with anxiety, 7.4% behavioral disorder. However, a concerning share of these patients, unfortunately, do not receive therapy. Meanwhile, during this COVID-19 period, it has catalyzed us to using virtual care, telemedicine in one platform or another in the last 8 months in a way that no one could have ever foreseen. Shifting, according to CMS or Medicare, 9 million Medicare beneficiaries received telehealth services during the public health emergency from mid-March through just mid-June. Prior to March, just 13,000 telemedicine visits were conducted each week. This is providing a great opportunity to reach more patients. And I encourage all of you, whether it's the standard TelDocs or UpDocs or the standards, or now the fact that some of these are being waived, even FaceTime or Skyping, meet with your patients and more efficiently connect with them with the needed services, even if it's through the phone. This is true across the spectrum of behavioral health patients, which my respected colleagues, my psychiatrists, were starting earlier, even before the epidemic. Primary health care was just starting during the epidemic. and it's true across all spectrums, including patients seeking treatment for substance use disorders, whom I care for as an addiction specialist. So after this shortly, I will introduce, and Dr. Degruy and Dr. Shore will follow me. That then will be followed by Dr. Barry Sarvet and Dr. Pring. Now, what I want to say, although I've had the opportunity working for a federal qualified healthcare center, which offers so much services, I have noticed that even in my small primary care practice, we can provide great services and look to the community. So 3 last talking points before I hand this over. Having a strong collaboration on my team with both clearly defined roles. Each clinician or member of our team has that, but we also do work as a team. If somebody is out ill, we clearly define some nurses who will conduct an intake, they'll conduct a history and an initial screening on a platform basis. Then what we call is a warm handoff. They will then hand it off to a physician assistant, a nurse practitioner, an MD, or a DO when working with these patients to provide comprehensive care in the community is especially critical for the medication-assisted treatment patients. And what we've all noticed is a unique challenge because it's hard to, especially with the new patients, not to be able to see them live. So we'll get into that in a little bit. In 2019, a systemic review of research on telemedicine or teletherapy for patients with substance use disorder found that many models of care delivery result in a high patient satisfaction. So if we can't provide face-to-face, at least we can provide that. Secondly, my second talking point is building strong relationships. Yes, you folks out there may not have all the resources I do in the community government clinic, but if the MAT patients I see very often come in with comorbid mental health conditions, we can treat certain patients within our practice. We do not need to refer unless they have more severe conditions. In these cases, we have developed strong relationships with the psychiatrist, with a social worker, with a peer coach in the community, and we will actually make the appointment. And we will make the appointment for our patients to see them after they see us. We will also give them the demographics to make it easy. So with MAT patients, especially those with comorbid mental conditions, loss to follow up is always a concern. So this warm hand up, when you make your connections with the community, since you may not be able to provide those services, is key. And lastly, detailed interviewing is needed to successfully build a relationship with the patient. When working to support these patients in a virtual world that we are in today, a little extra effort is necessary to build that relationship, especially with a new patient that you don't know that well. We take every effort to, especially the critical patients, when we work to meet the mental health needs of our patients. To this end, my team and I will often set aside a few extra minutes with our newer patients so that we can learn, we can look at them and get a sense to, because we do not judge and we take everyone that comes before us, no matter what background. So if I have to stress one last thing, building the relationships with the community is key to delivering successful care. While all our practices are facing challenges in this time, it is key to take this opportunity to embrace technology using virtual care. And before I leave you all, it's not just that we're being reimbursed finally over 3.5 decades of my life, finally in practicing medicine, but we can use all the tools that we have, whether it's the phone, whether it's telemedicine. I want to embrace all of you to please try to integrate this and go ahead and use your telemedicine skills. This being said, I'd like to carry on with meeting our next speakers, our psychiatry friends, Dr. Degruy and Dr. Shore. Please go ahead and take over.
Thank you, Dr. Laskowitz. I'm Frank Degruy. Turns out I'm a family doc and not a psychiatrist. I chair the Department of Family Medicine at the University of Colorado on the Anschutz Medical Campus, where I've been for 20 plus years. Jay is a card-carrying psychiatrist, a professor in the Department of Psychiatry, and the director of telemental health services there. One of my closest and dearest colleagues, and someone with whom I work very closely to develop advanced models of care, both in the primary and the mental health setting. Next slide, please. You can read, and so there's no use in my reading it. Next slide, please. These are the objectives that Jay and I hope to accomplish today. We first want to characterize how we're using telemental health care in primary care. And we next want to describe the advantages of telehealth. We've all sort of been forced into using it much more extensively than was true 8 months ago. But even 8 months ago, the advantages of telehealth were emerging very clearly. And so we're going to try to describe what some of those advantages are and under what circumstances you can use telehealth services to maximum benefit. Next slide, please. Now, I want to make a point before we get started in describing how we use telehealth services. This is a slide which describes the most recent of many descriptions of the models of integrated primary care that are at play in the US and really in the world today. This is data that just came out a couple of weeks ago, 2 weeks ago. It's from a sampling frame of over 500 primary care practices that represent care for over 3 million patients who get access to integrated care services. Over half of those were safety net clinics. And if you look at the right-hand column, what you'll see, first of all, is percentages that total up way beyond 100%. What this should say before we even describe the particular models of integration that these primary care practices use is that most of them use more than one model. I'll give you a quick example of that. PCBH stands for primary care behavioral health. Some variation of a model which includes primary care clinicians integrated with embedded behavioral clinicians who function in the clinic as primary care clinicians, primary care behavioral clinicians, embedded in a team-based model of care. That does not preclude the use of and the design of collaborative care, which, as you probably know, consists of a primary care clinician, a care manager, and a consulting psychiatrist. That is a model that often coexists with a PCBH model. And you can see the other MAT, SBIRT, marriage and family therapy, addiction, specialty medication. There are a range, a bewildering range of variations and combinations of primary care that is subsumed under the label of integrated care. Next slide, please. These are the basic elements of all of those variations in some form or another. What you see at the 12 o'clock position are primary care clinicians. Those are family docs or general internists or general peds, NPs and PAs and others. The primary care clinicians are at the heart of the core primary care team. At the 3 o'clock position, you'll see embedded primary care behavioral clinicians, psychologists, social workers, MFTs, and others. At the 6 o'clock position, you see primary care psychiatrists, a role that Jay will describe in much more detail in just a moment. These are psychiatrists, psych NPs, and others like that who do deep end or difficult primary care work as part of the team. And then at the 9 o'clock position, you see care manager, a position that's dedicated to integrating these positions into a coherent team. Next slide, please. And I'm going to turn this over to Jay at this point so that he can describe for you within that universe of clinicians that constitute the team, what's done in a direct physical person-to-person space and what's done in a virtual space. Jay, I'm going to go on mute.
All right. Thank you, Frank. I think we're all right now pretty much working in a virtual world. And certainly as the opening remarks, the acceleration of us using telehealth because of COVID, both the current acceleration, but I don't think things will go back to the way they were before. And what that means is all providers will really be working in this hybrid care model, meaning we will work and use multiple different technologies and media in dealing with patients. So we'll hold relationships virtually via video conferencing, telephones, email, patient portals, and we'll see patients in a variety of settings in person. And I will sort of get back to this, but it's really in this context of the hybrid universe that we need to begin to be thinking about virtual integrated care. Next slide. So this is a figure that I like from the Kaiser Family Foundation that sort of simplifies these models on a continuum of integrated care. Everything from really on one end of the continuum where you're just doing some mental health screening to fully integrated care clinic, and there's various definitions of this. And I'll return to this chart in a minute, but really what's happened, particularly with technology, is next slide, please. We use this host of technologies that I mentioned, both patient-facing, medical team-facing, mental health-facing, to interact and begin to overlay the ways the technology can enhance this integration into these models. Next slide. So we return here to this slide, and you can see that, at the very one end of the basic level of the continuum where you have coordinated care, patient education, you have echo style grand rounds. Moving up that continuation, you have things like e-consultation or direct telepsychiatry consultation, things like store and forward telepsychiatry. And then at the full end is this full virtually enabled integrated care model. Next slide, please. Where, this is an illustration of different ways and pathways that technologies can connect the different types of professionals, everything from the providers and case managers with the patient or patients. And it's really within this web that virtual integrated care exists. To give just a very brief example of this, next slide. In Colorado, we have something that we call Integrated Behavioral Care Plus. And this is a model, as Frank described, its foundation is having an embedded psychologist who used to be, and now everything's virtual, but before COVID was physically embedded in this behavioral health team, along with other behavioral health support and case management, and then the full complement of the primary care team. And then layering in on top of it was psychiatry, which was coming in virtually, and doing a step care approach to a touch with the patient, starting with e-consults, provider to provider consultation via email, phone, and video, all the way up to doing co-consults or team meetings with the patient in and out of the room, and then all the teaming approaches that are needed to solidify the teamwork of integrated care. Next slide, please. And this is actually a model from one of our clinics that really shows how this really gets put together and operationalized on a pragmatic level. So you see that this is an integrated care service across 7 family medicine clinics. So you can see Family Medicine Clinic A has its family medicine providers. It has its embedded psychologists and then you can see up top it has telepsych coordinators, MAs, and other support. And then on the psychiatry team, you have this lead clinician, and they're doing weekly team telepsych huddles, discussing cases, seeing patients directly as individuals and as team members. And then you can see on the other side of that bubble that Clinic A psychiatrist is part of a larger psychiatry team that's also servicing other clinics using the same model. And that team also has a weekly meeting. And so this is really about sort of getting the details of operation. Next slide, please. So, and I'll let Frank start off, but we're going to talk about just some of the common sort of pitfalls and challenges of doing this well.
Thank you, Jay. So Jay showed you a set of slides that describe the hierarchy, the levels of integration, and what really in truth is a fairly complex set of relationships between the behavioral clinicians, the primary care clinicians, the patients, the care managers. But it can be reduced to a fairly simple and straightforward set of principles. If those principles are not followed fairly carefully, the proposition for integrated behavioral health and primary care can easily come unraveled. So I'm going to talk about some of these on the primary care side of the river, and Jay will talk about them on the behavioral or psychiatric side of the river. If the primary care clinic is led by someone who is clear and consistent and who can make decisions that represent the best input and the best data from the team and can commit to following through on the decisions that can be made, integrated telehealth has a chance of working. But you absolutely have to have a clear and decisive leadership that listens and makes use of all of the team members. One of the most important means by which making use of all of the team members occurs is represented by the second bullet. Under communication, defective teamwork will break telehealth and telemental health very quickly. It requires a team that is flexible, in which the hierarchy is relatively flat, in which any member of the team can go in the lead in terms of taking care of the problem that the patient is representing, according to whoever is best suited for dealing with the problem at hand. There's also a need for having a fairly careful and fairly well documented workflow. The capacity for workflow needs to be laid out, and it needs to be understood by all of the team members how and under what conditions a televisit occurs, what it takes in order to do that. And it needs to not only be clear, but it also needs to be very flexible, because in the primary care setting, stuff comes up out of left field all the time. And finally, you actually have to have someone on hand who's mastered the technology so that televisits can happen, so that you can actually see each other on the screen, and that you can sign on and sign off and make that part of the electronic health record clearly. Those are the pitfalls without which telehealth is difficult to do. Jay?
And very much in a parallel manner on the psychiatry side, and particularly for psychiatrists, it's sinkholes or pitfalls include of a hierarchical approach. Many of us have been trained in more a hierarchical model and don't get a lot of team-based care training. And hopefully that's changing, but being able to be flexible, to be able to demonstrate leadership on a team, but not taking a hierarchical approach, really facilitates the important work that needs to happen for team management and dynamics. And psychiatrists have a unique sort of leadership role, but leading doesn't mean always being in charge. And I think that sometimes takes a lot of experience for clinicians to come to terms with. And then I think the other really and critical point is not having a really good understanding of primary care, really understanding the pressures of your colleagues in primary care and their perspectives, so you really can be of service to them as you're working for. And it gets back to understanding the culture of primary care, as well as the specific clinic and workflows. As my mentor, Frank Degruy, says, good integrated care obviously needs good workflows and structure, but it also is a bit of an art, and it becomes a dance, and a really a good dance. When you first start to dance with a partner, you may step on each other's toes, but if you keep practicing, it becomes a fluid and a thing of real beauty. But that takes time and sort of willingness to let your toe maybe occasionally get stepped on when you're learning the first few steps. Next slide. And Frank, I believe this is your slide.
Yeah, I don't need to belabor this slide, but I wanted to put it up here because I described pitfalls on the one hand. This is the converse of that. If you are getting into the business of doing mental health care, these are the issues, these are the domains which you need to pay attention, learn, and acquire mastery in order to succeed. And remember that the point of doing this is to produce a comprehensive and a coherent or integrated personal care plan for the patient. Next slide. This is today's slide.
I would just end with saying that the teams and each team member needs to always display a high degree of tactical flexibility. Those may recognize this slide as the Dread Pirate Roberts battling the giant Fessick in The Princess Bride, and he was able to overcome the giant because he just got used to fighting large groups of people and hadn't honed his one-on-one skills. And so it's really important to have a good degree of tactical flexibility when doing integrated care. Next slide. I believe you'll have access to the slide. So this is just some resources here, and both for telepsychiatry and some integrated care, some starting points. And then next slide is also just our contact information for follow-ups or questions. If you wake up at 3 a.m. and have a burning question that didn't get answered on the webinar, Frank and I would be happy to help cure your insomnia, although we may not respond at that time. So thank you, and I believe we go on to the next segment now.
Hi, everybody. Good evening. So we can move on to the next slide, which will be kind of like the welcome slide for the talk. So Dr. Pring and I are from Massachusetts, and we're going to talk with you about the Massachusetts Child Psychiatry Access Program. The Massachusetts Child Psychiatry Access Program, which we refer to in shorthand as MCPAP, is part of a larger context. It's the first program of its kind, but now we talk about this term CPAPs, which is more the general term. And this is a model that's been spreading across the country. It's a remote population-based collaboration model, and it is considered to be a telehealth type service But we should emphasize that unlike other kinds of telehealth, it's really not a very kind of technology kind of dependent service, because the remote aspects of it are basically telephone conversations. And it involves seeing patients as well. And of course, we're just like everyone else, seeing all of our patients through telepsychiatry, televideo, video conferencing technology. It doesn't have to be that way, and so it is a remote type program. It's a public health infrastructure model, really, because it really is a model that's almost always funded by states or municipalities. And it really is devoted to practices that are distributed across a geographic region. And so I'm going to talk a little bit about the program model. We've been doing this since 2004. It's proven to be sustainable, and it has spread to 38 other states. And so if you throw a dart at the map of the U.S., you're likely to hit a state that has one of these programs. Dr. Pring is going to talk about the experience of being a pediatric primary care provider, really on the other side of the collaboration relationship. Next slide, please. So the purpose of MCPAP and pretty much all CPAPs is really to support the role of pediatric primary care providers in addressing the mental health needs of kids in the primary care setting. And it really does that through connecting practices to the actually there's a typo in this slide. I should say I made a typo in this slide. It's not just there, to the psychiatric healthcare system. So really kind of create connections between primary care practices and the whole world of psychiatry and the whole system of care, and really is to improve the quality of mental health service delivery in the primary care setting. And essentially, I think point really needs to be emphasized along the lines of it being not a technological sort of program per se. It really is like a system supporting the building and the cultivation of relationships between child psychiatry folk and pediatricians. And historically, we have to acknowledge that the relationships have been pretty lacking. Next slide, please. So this is basically how it works, at least clinically. These programs usually have a hub and spoke model, and there are these teams that are located centrally within a region, and then their primary care practices, throughout that region. It's like a catchment area, hence the notion of a public health model. And so all of these practices have access to a hotline, and whenever they have a question, whenever they're seeing a patient that has a mental health need, they can call the hotline, and they always get initially a telephone consultation. And then the telephone consultation can actually be provided by a child psychiatrist who's on call all the time and really dedicated to this work. There are also multidisciplinary teams, so that we have therapists that are providing telephone consultations, as well as care coordinators who can help with resource navigation. And then after that initial telephone conversation, that we can go on and see the patient in person with a face-to-face evaluation. Again, during the pandemic, it's almost always over video conferencing. We can actually do some interim psychotherapy with the patient, and then we usually pass some work over to a care coordinator who can help the pediatrician and their practice with trying to access resources. And so the whole purpose of this is really to help primary care providers to have the tools that they need to take care of their patient. Next slide, please. So the services of these programs, I already mentioned, several of them. The one that I didn't mention is training and education. And actually the training and education piece comes in two ways. One of them is through a traditional CME program, because the CPAP programs usually have a whole strategic plan to offer CME products and different kinds of services to pediatricians that are really designed specifically for primary care providers. But every telephone consultation and every face-to-face assessment really is kind of like a teachable moment, practice-based, kind of educational service. Because again, the care is being provided by the primary care provider, and all the advice and consultation that we give is educational in nature. And we're not sort of dictating what the plan is going to be for the patient. We're giving advice, and then the pediatrician can decide what to do. Next slide, please. So we like to think of these programs as really relying on this notion of a three-legged stool, in the sense that there's no one thing that's really enough. Of the services that I described, telephone consultation is the starting point, but it's never enough because you're answering questions over the telephone, and almost always the answer to the question is not all that the pediatrician needs. So sometimes you can't answer the question because we don't have enough information, and we don't have enough knowledge of what's going on clinically to really give a good answer to the question. So all these programs really need to have provisions to be able to do face-to-face consultations, which is the direct patient evaluation, which is expedited and really designed to provide kind of a confirmatory consult, or really to help with diagnostic accuracy, so that we know what we're treating. And then referral resources, that we can have all kinds of great ideas as far as what to do. The pediatrician always has their prescription function, but the pediatrician is unlikely to be doing psychotherapy, and almost all care of children with mental health problems requires a team. So you have to have a treatment plan, you have to have a team, and pediatricians really need help with resource navigation. So it is a three-legged stool, and I think without one of those components, the programs don't tend to function very well. Next slide, please. So this is just some data. I want to keep this practical, but the point is that we've studied the program, and we found that there's been significant enhancement in the pediatricians' really feeling of confidence and competency in terms of being able to take care of kids with psychiatric problems. I should mention that that we don't support the idea that pediatricians should have to take care of every patient with a mental health problem. We're really kind of focusing on what we consider to be potentially within the scope of practice in primary care, and we kind of help triage sometimes on these telephone consultations patients who really need to be seen by a specialist. That's a fluid kind of distinction, because in some areas the sort of child psychiatry scarcity is much worse than others. And so we have to take into consideration sort of the resources and also the interests of pediatricians and their kind of sort of willingness, to take on this role. Next slide. So just a few things about best practices of this program. So again, it's a relationship type program, and so and it really depends upon pediatricians having the motivation to call. So the practices that call often get a lot better service from CPAPs because the service is really provided at the prompting of the pediatrician reaching out and calling. We do some outreach, and we're actually developing models of outreach so that we don't have to wait until the pediatrician knows that they have a question, because of course not everyone knows what they don't know. But this notion of these telephone conversations, it really over time, when there are many of them, it really builds a very rich relationship, and we're able to cultivate very warm, collegial, sometimes so nice in that pediatricians who we've never actually seen, oftentimes, in sort of with our eyes that we've interacted with them, but sometimes they maintain relationships with us where we talk with them about their own personal needs and issues, and there's a sense of trust that builds up. And it is derived from a time-honored tradition of curbside consultation. Next slide, please. So I mentioned that every telephone consultation is an educational encounter, but I would also say that the face-to-face consultations is like precepting. You know, for anybody who's been involved in residency education, I'm sure everyone has done a residency and has had experience, you know, precepting. And, you know, so it's one thing to hear a case and to have advice, you know, to give advice, but it's another to have a telephone conversation and then see the patient and then, you know, have another conversation to really go over, you know, what the pediatrician thought and what we thought and compare. And that's a powerful learning tool. Next slide. So I already talked about the fact that these telephone consultations really build the relationship, and there's lots of, you know, pieces to the craft of doing this that makes it work. It's not for every child psychiatrist, because some child psychiatrists literally make pediatricians feel nervous because they focus more on kind of the complexity and not on the things that are sort of straightforward. And so there's different best practices about how to, you know, make these telephone calls a positive experience so that you get calls again. Next slide. And then finally, I just want to sort of point out that we recognize, you know, the limit. One of the biggest limitations, I think the biggest limitation of the CPAP model, is that if the PCP doesn't know, you know, that they have a question and doesn't really have kind of a very active engagement with patients around, you know, behavioral health needs, because they may not be interested, they may be afraid, then it doesn't work, because the PCPs won't call and then they won't get the services, their patients won't get the services of the program. And so one of the solutions to this that we've really worked on is to try to develop some hybrid models with some of the other integration models. So one of the most exciting ones that I'm really interested in and have been working on piloting in Massachusetts is to utilize this infrastructure of the CPAP to deliver an adaptation of the impact or collaborative care model, you know, which involves an embedded clinician, a behavioral health clinician, care manager working in the practice, and the child psychiatrist, instead of waiting for calls, would have weekly meetings with the embedded clinician to go over the caseload and then generating ideas, you know, that could be shared and would be shared with a pediatrician about things that could be done medically. And so so that's kind of one of the most exciting frontiers, I think, of MCPAP and other CPAPs. But I think I'm going to go ahead and hand it over to Dr. Pring as the next step.
Thank you. And yes, I'm a general primary care pediatrician. I practice in Boston and have had the great opportunity to have a lot of helpful experiences with MCPAP. So as Dr. Sarvet said, you know, the program, and you can go to the next slide, please, is really sort of, I see it, there's, I think he used a stool and we had all of those parts, but there's sort of the educational component and also the practical component, which then gets back to the educational component. So in my large practice in Boston, believe it or not, you know, Boston, which has a ton of physicians, we also have difficulty with access to child and adolescent psychiatrists. So we do find this program to be very helpful. And some of those things that that Dr. Sarvet was talking about, the offering different types of resources. I just received in my email today, it's very timely, about a webinar on Wednesday next week at lunchtime for primary care physicians and pediatricians. And so MCPAP does these periodically on top of having a very useful website, and then really some really great other general basic what, you know, to the psychiatrists in the audience will think is super very basic bread and butter psychiatry, but for some of us pediatricians, it's a little bit more, you know, basic things on how clinical pearls for handling ADHD and starting a new antidepressant and sort of diagnostic checklists and treatment algorithms or types of medications we want to use. And for many people that might seem like something that's very easy. We prescribe antibiotics all the time and know which one's the best one. But when it starts with, you know, well, which antidepressant or anxiolytic should I go for? I think that these are great resources. I will just advertise, this was, it's probably hard to read on camera, right above my desk. And when I was preparing for this talk, I went around to my colleagues' offices and they all have this really great book that MCPAP sent to us. So I just think things, some of the learning is with the interactions and some of it continues to go on. Next slide, please. And so, my experience really, as I talked about, some of it is with learning, but also really the consultation process, which obviously builds learning. And as we all know, we learn more from experience than from just textbooks. And I just thought I'd share a specific example I have with you. I know we want to get to your questions, and I just as a general pediatrician, I think I've had a benefit of learning a lot from these interactions with MCPAP. Next slide, please. So I thought I would just sort of share a typical case for you. Any primary care physicians in the audience may have gone through this kind of experience where it's late in the day. I have a new patient on my schedule. This happened to be a 15-year-old, comes in with his father. He had recently relocated from Maryland, where he lived with his mother, and had been in some kind of group home for quite some time, and had moved to Massachusetts. Father hadn't really been that involved with his care in the past, but knew he had maybe a diagnosis of a mood disorder and ADHD and some tics, and had a bag of sort of medicine bottles with prescriptions that were kind of running low and had run out. And the child at this point was starting to become more angry and very sleepy. And his tics were starting to act up. And so here I was in sort of that typical situation where we need to do the right thing. I know I'm not necessarily the right person for this, but this patient needed a lot of help and needed it quickly in a sort of a setting where we didn't have instant access to the right kind of specialists for a visit in person. So I was able to reach out to MCPAP, who right away, following that great flow sheet that you saw, all sorts of things happened, what seemed to me very seamlessly, and I don't know what happens on the back end, but I was able to speak with a child psychiatrist who was able to help me. This patient had been on risperidone, which I had never prescribed, gave me some recommendations for dosing, what labs I needed to run, an EKG management, and things that really would have overwhelmed me. And I would have, in another situation, just probably turned the patient away and said, I can't help you. Not turn them away, but not, just wouldn't have felt comfortable writing a prescription for medication without that kind of support. And then, what was really wonderful is they were able to get him in quickly for a consult. And then, even more amazingly, in my opinion, was, feedback back to me with information on sort of what we should do about the medications that were sort of affecting this child, that were making him sleepy or, making him angry, or the lack of some of those medications. And then able to give me and the patient a list of providers that took his insurance and that had an open practice. And that was really impressive. I just think that doesn't always happen so much. And then I just felt overall that it was a really warm handoff and a really great sort of wraparound care with a great opportunity. And that was just sort of one example of the way that the relationship with MCPAP can start with one patient and then continue on to others. Next slide, please. And so I thought that was probably all that I, wanted to sort of highlight, is just how it really can be a lifeline. I think a lot of pediatricians and primary care physicians are comfortable with some treatments, but like Dr. Sarvet said, there are certain ones of us that are more comfortable and certain that aren't, and this really helps us sort of become more comfortable. With that, I think I will pass it on back to Dr. Leskovitz.
Well, thank you, everybody. I want to thank all the participants. And are there any questions from the chat? I see, myself, one of the questions I may have for all the pediatricians and the psychiatrists, as far as telemedicine and in your field, often, we are faced, one of the largest diagnoses is attention deficit or hyperactivity, or not sitting still, not doing good in class, creating stress with the family, etc. So in person, it seems there's some easier, but I would imagine you've been faced with some obstacles with telemedicine. Can you briefly go over those obstacles and maybe what you do in your models to try to face those? Dr. Degruy, or can you hear me?
Yes, I can hear you. Was that a question specifically for the pediatric practices?
Pediatric practices in particular, with telemedicine, I would imagine, has there been some challenges, or I'm sure there are, as opposed to having that child there in front of you?
At the risk of being inappropriate, it might be that Doctors Sarvet and Pring would be better equipped to deal with that question, since they live more completely in the pediatric space.
I guess I'll just say, I'm, in terms of the pandemic, and from face to face, we actually are seeing a fair amount of patients in the office, but something like ADHD, I think for us is, we do a lot of diagnosis based on the symptoms, and that actually is probably easier to manage with sort of questionnaires and things like that from the parents as a remote. So the face to face versus in person for that, I don't think is as challenging. I'm not sure if Dr. Sarvet has anything to add.
Yeah, it's not clear to me sort of that we, have trouble with, kind of pitfalls or, troubleshooting kind of needs, with this program. Again, because it's an old-fashioned relationship program, so we don't depend upon, the vagaries of technology so much, certainly with, video conferencing. But, it is and also we're not trying to take care of the patient, remotely either, that we're really trying to be able to offer good direction and advice to the pediatrician. So and it's true that telehealth for psychiatry, it's such a natural. I mean, I'm sure Dr. Shore, could speak to this more eloquently, but we actually don't touch patients, very often, and we try not to, and so having that distance, is actually okay. It becomes very challenging for young children. I will say that when you have toddlers, it's very difficult, to keep their attention, keep them engaged. That when we're in the office taking care of young kids, we're kind of following them around the room and trying to play with them and trying to attract their attention with toys and things like that. And that becomes very difficult. But otherwise, I think, we haven't, had much trouble, utilizing different kinds of tactics to, really understand, sort of what's going on with patients from a distance.
Great. Thank you. Thank you, Michelle, for the kind words. And Patricia, Ms. Gibson, to answer your question, the insurance companies and government, the government has waived, the Ryan's law so that we can use telemedicine. I've noticed that some of the co-pays are being waived, and all insurances, as far as I know, have been kind enough to, pay a decent fee for telemedicine. So you may want to reach out to your insurance companies or to your organization, but I from the billers I know at the private practices, small practices are doing very well with telemed. Just there may be a code to add. I don't have offhand, but I will get that for you and encourage you to to do that. And the biggest points from tonight was the collaboration with the pediatricians, the psychiatrists, the primary care. And early on, we heard that virtual medicine is here to stay. I don't think we're ever going to go back. So I encourage all of you, as you solely or go out and integrate, to reach out and to continue to use these phone calls and telemedicine platforms, if that's works best for you. I want to thank the people who put this on, the AMA, the AOA, and all our presenters today. Thank you all, the attendees, for being here. And I want you all to have a really good night. Thank you.
Thank you all. Thanks for having me.
Thank you.
Okay, thank you all. We are at the end of our time for today's discussion. The next webinar in the series is scheduled for Thursday, November 12th. And at that one, we'll be discussing financial planning strategies for BHI. If you were unable to attend any of the previous webinars in this series, the link to the webpage is in the chat box. And thank you all again, and hope you enjoy the rest of your evening.
Thank you. Have a good night.
And for those of